Okay, so good evening, everybody. And it's indeed a pleasure to invite you all for this postgraduate lecture series, which had been a bit interrupted in between because of various reasons. And the topic that we have chosen today is very, very relevant. And over the next 4 weeks, we'll cover different aspects of calcium problems and pathophysiology, including hypocalcemia, hypercalcemia, rickets, and renal tubular acidosis. So before we start, Dr. Vibha, why do you think hypocalcemia is so important? And what are the usual situations in which a pediatrician should be aware about that this child we are dealing with may have hypocalcemia?
So, as calcium is very important for nerve excitability, muscle depolarization, nerve cell depolarization, so it is very important to look for the calcium levels. And in this scenario, we must keep our eyes and ear open. It should be like unexplained seizures, apnea, evident tetany, and either there is an unexplained cardiac failure. So, in all these sort of conditions, we should be very cautious about what is the calcium level in the sick neonate.
Definitely. And Dr. Dhwani, what do you think are the most common causes that pediatricians will see in terms of hypocalcemia in their practice?
Yes, so the most common cause that pediatrician will come across is rickets. Apart from that, one may see CKD cases, one may see pseudo hypocalcemia in cases of nephrotic syndrome. In cases of SAM, you will see hypomagnesemia leading to hypocalcemia, hypokalemia.
So a lot of nutritional factors like magnesium, vitamin D are the pivotal roles. So what we'll do now is that we'll start off with a very, very interesting case whom we saw recently and who has got a lot of implications in terms of why we need to really evaluate and assess in terms of hypocalcemia. So this is not really a recent case. A long time ago, I saw this case around a couple of decades ago. So this was a 2-month-old boy with respiratory distress who also had hepatomegaly and cardiac failure, was in fact admitted under the cardiac unit. So this child was admitted as cardiomyopathy in the cardiac unit with a very low ejection fraction. And at that point of time, when they evaluated further, they found that the child actually had prolonged QT interval and was found to have hypocalcemia. And then the referral was done to us. And what we found that this child actually had a vitamin D deficiency. And now we know how severe vitamin D deficiency can cause cardiomyopathy. Now, this was those early ages when this was not really easily available and was not really informed. So unfortunately, this child had to go on ventilator and a lot of other complications happen. But till date, also, we occasionally see patients with cardiomyopathy. So hypocalcemia is a significant cause of concern, and we need to have a proper evaluation, assessment, and management to identify in that regards. All of you can go and have a look at our website, learning.rosesociety.in, which has got a lot of information about pediatric endocrinology, including e-learning resources in the form of YouTube videos, our platform, which has got validated tools for assessment, as well as courses for fellowship programs and postgraduate programs, also courses, which are a lot of modules available. We routinely conduct grand rounds, the postgraduate lecture series, as well as specific rounds related to pediatric endocrinologists on a monthly basis. We have got publications which can be accessed both in an e-version as well as the hardcore version and the mobile application, which really allows evaluation and management of pediatric endocrine disorders very easily. So what I'm going to do today is that we'll talk a bit about pathophysiology to begin with, then we'll talk about criteria and etiology. And then from there, we'll talk about assessment, management, and finally, since this is directed more towards pediatricians and postgraduates, we'll also have some very practical questions which have been prepared in the form of OSCEs, as well as questions which will be highlighted from that regards. So when we talk about calcium, what you need to remember is that 99% of our entire calcium is actually in the bones, and only 1% of it is actually available in the blood. Now, here this calcium is bound largely to substances like albumin and phosphorus, and only 50% of it is free. It is a free calcium which is responsible for the action of calcium in that regard. Now, very importantly, the anionic component of albumin, which bounds to calcium, is dependent upon pH. In scenarios wherein we have alkalosis, whether it's respiratory alkalosis or metabolic alkalosis, we will have increased anionic albumin, causing decrease in ionic calcium, resulting in hypocalcemia. So alkalosis may predispose hypocalcemia, and this is something which we often see in the setting of renal failure, where there is a subclinical or covert hypocalcemia, and once somebody is given soda bicarbonate, suddenly the acid-base balance shifts out and one develops hypocalcemia. This can also happen in the setting of hyperventilation, in the setting of conversion reaction, or also in the setting of hyperventilation in terms of when we are using excessive settings or the ventilator and soda bicarbonate treatment. Now, the calcium homeostasis largely revolves around three major organs: the intestine, which produces the chronic source for calcium; the bones, which provide the acute correction as far as calcium levels are concerned; and the kidneys, which are mainly providing the excretion, which has a minor role in terms of evaluation and in terms of management. Now, in the settings when the calcium levels go down, the calcium sensing receptor activity becomes less, and the body senses that, okay, we are less in calcium, and the primary player in the overall regulation comes into the picture, which is the parathyroid hormone. And this parathyroid hormone has multitude of effects. It decreases the urinary calcium excretion while increasing the phosphorus excretion. So anybody who has got hypocalcemia should have a hyperparathyroidism, should also have phosphaturia and hypophosphatemia. So hypocalcemia and hypophosphatemia go hand in hand. If you have hypocalcemia with a high phosphorus, you're dealing with either a renal failure or a PTH problem, or really a phosphate load in that regards. However, the major role of PTH in calcium regulation is in fact the activity of 1-alpha hydroxylase, which is stimulated by it, resulting in production of calcitriol, which is the only hormone which regulates the calcium absorption via the intestine. PTH also has an effect on the bones. It allows the calcium to come out from the bones. So PTH basically is a hypercalcemic hormone, and it acts in synergy with calcitriol. Now, in scenarios where the calcium levels go up, the body has got another mechanism, which is the calcitonin produced via the parafollicular cells of the thyroid, which decrease the bone resorption and have some effect on the renal excretion. Now, what we need to remember is that as for any evolutionary process, the body has been evolved towards preventing hypocalcemia rather than hypercalcemia. So what we need to understand is that in that setting, the hypercalcemic hormones, the PTH and the calcitriol, play a major role, and calcitonin plays only a minor role. Remember, in conditions where the complete thyroid gland is removed, there is no calcitonin, still you do not develop hypercalcemia. Similarly, in scenarios where there is excessive production of calcitonin, like medullary carcinoma of thyroid, you do not develop hypocalcemia. So the overall effect of calcitonin is mild, it is transient, and it develops very rapid tolerance. So body is tuned more towards maintaining hypercalcemia than hypocalcemia. So PTH is by far the leading figure as far as the regulation is concerned, and calcitriol may be its mediator. Now, as I said, the major chronic role as far as calcium levels in the body is the intestinal absorption, and intestinal absorption happens there largely in the dairy products. It's also in some of the green vegetables. And this calcium can be absorbed through two routes. So we have the route which is basically there through the paracellular, or one which goes through the cells. Now remember, if you are taking a lot of vegetarian diet, there is more phytate, which decreases the calcium absorption. So does the intake of a lot of these soda products and colas, which also will cause calcium deficiency. Now, if we talk about the calcium absorption through the paracellular route in between the cells, this is a passive process. This process is not regulated. It is not regulated by the calcitriol. So if you're taking more calcium beyond a particular level, beyond 1500 milligrams, you will have hypercalcemia, which may happen in that setting. The transcellular process through the calcium process is actually a very active process. It requires a lot of energy. It requires channels which take in calcium inside. So we have got the TRPV6, which is there in the duodenum and which is basically affected by a fasting, while we have got the calcium voltage gated channel in the jejunum. Now, calcium absorption basically through the TRPV6 usually happen in the fasting state. Once in the cell, this calcium binds to the calcium binding protein, which then takes it through, because calcium, of course, is not going to move out very easily. It has to be transported. And this cal binding protein will then shift this calcium out to the calcium ATPase channel. So this is a very active process. And the major regulator of this active process is calcitriol. In the absence of calcitriol, only 25% of calcium absorption happens, while when you have sufficiency of calcitriol, this absorption goes up to around 40%. So if you talk in that perspective, the only major role of vitamin D pathway, including the receptor and calcitriol, is to increase the permeability of the intestine to calcium. As the only role of AVP in the water regulation is to increase the permeability of the collecting duct to free water, the only role of aldosterone in regulating the sodium is to increase the permeability of the collecting duct for the sodium. So what you can understand is that calcitriol requires calcium intake. If you do not take any calcium, you may have huge amount of calcitriol, you will still not get enough calcium. So dietary calcium intake also is very, very fundamental from that perspective. Now, as I said, renal handling of the calcium is not a major player, but it may have significant implications in making the diagnosis, as well as implications in terms of renal calcification. So of the maximum amount of calcium which is actually filtered, 70% is absorbed at the level of the proximal tubule, largely using the calcium sensing receptor. Now, this calcium sensing receptor is sensing the calcium level. If the levels are high, it says, okay, PTH, you shut down, and urine, you excrete more. Now, if you have scenarios where you have an activating mutation in the calcium sensing receptor, or there is an antibody which stimulates the calcium sensing receptor, the body, in the absence of hypercalcemia, will behave that it has got a lot of calcium. The PTH levels will go down, but the urinary calcium will continue to go up. So this will be a classical scenario of hypocalcemia with hypercalciuria, which is a very, very important condition to identify, because in this case, if you keep your calcium levels high, you will have a risk of developing nephrocalcinosis. Now, of the remaining 30% calcium which is left, a significant chunk is absorbed at the level of the claudine 1, which is the descending loop of Henle, where it acts, and claudine defects, as we have discussed earlier, are known to cause hypomagnesemia. It's only the 10% calcium which is there in the distal tubule whose absorption, around 50% of which happens, is regulated via the PTH. So the PTH effect, as far as calcium absorption is concerned, is not significant. But this 5% is very, very important, because in somebody who has got hypoparathyroidism, PTH cannot conserve calcium. So if you raise their calcium levels to a particular level, you will risk a scenario of hypercalciuria, resulting in nephrocalcinosis. So the targets for treatment in the setting of hypoparathyroidism are much lower as compared to the other scenarios, and this is something you need to be very much aware about from that regards. Calcitriol has got a very minor effect here, and we know that thiazide are going to decrease the urinary calcium excretion, while furosemide increase that in that regards. The third major player, of course, is bone, which is the chronic store and which provides acute regulation of calcium. And this happens largely in the form of this exchange with PTH brings the calcium out from the bone at the expense of bone health. So if you have a chronic hyperparathyroidism, you will have a low bone mass and you will have decrease in terms of the bone activity. Calcitonin, on the other hand, decreases resorption, causing deposition of calcium, again causing hypocalcemia, and because phosphorus also goes in, the overall process will have a problem. So now if you look at it, the effect of these hormones, you look at PTH, it increases the calcium, it decreases the phosphorus, it increases the phosphorus excretion, decreases phosphorus levels, and decreases urinary calcium. Calcitriol increases both calcium and phosphorus absorption, causing hypercalcemia and hyperphosphatemia, while also increasing urinary calcium, while calcitonin causes hypocalcemia, hypophosphatemia, as well as increasing urinary calcium. So understanding the phosphorus and urinary calcium will give you a real clue in terms of diagnosis in that perspective. Couple of words about fetal physiology. What we need to remember is that there is an active gradient of calcium which is maintained between the mother and the fetus. So there are specific channels which allow this calcium to enter from the mother to the fetus. The fetus actually has 1.4 times more calcium as compared to the mother. Most of it happens in the third trimester. Now, this is regulated largely via the placental PTH-related peptide, which is the major regulator in that scenario. Now, this gradient basically plays an important role, but there is also an independent PTH axis which is there in the child. Now, after birth, immediately you've got cessation of supply. Now, as happens for the three major factors, glucose, warmth, as well as calcium, suddenly the supply goes down. So body has to work now to produce the calcium, and all the calcium that you have stored is going to be used now. The first response, of course, is to increase the parathyroid, which is going to take off the calcium from the bone. The calcitonin level will come down, and then calcitriol will play some role. Remember, calcitriol plays a minor role in the initial 3 to 4 weeks after birth, and that's why infants born to mothers with severe vitamin D deficiency will not have hypocalcemia because of vitamin D deficiency. They will have hypocalcemia usually to beyond 3 weeks of life, which is known as a late hypocalcemia. That is because the infant is not much dependent about the calcitriol level in that scenario. So because of all this process, you may have a good adaptation. The calcium levels will drop to the nadir by around 24 hours, and by 7 days they will become normal, and this dip is much more for preterm. And when we'll talk about etiology, Vibha will talk about how this becomes relevant from that regards. Now, calcium affects every part of the body, particularly the neuromuscular excitability. It also has a role in secretion of a number of hormones, gut motility, and bone. So calcium deficiency will result in increased excitability, causing spasm and seizures. It would have cardiomyopathy, as we discussed in the first case. It will have gut dysmotility. So hypercalcemia will cause constipation, and hypocalcemia may cause other symptoms as well. You may have rickets, of course, if there's a chronic calcium deficiency in that regards. Now, in this background of these three major organs, the intestine, the kidneys, and the bones, and the three major hormones, the PTH, calcitonin, and vitamin D, we can classify hypocalcemia to be false hypocalcemia. You can say a condition in which there's an ionic calcium defect, which is because of chelation. There could be a PTH related problems in the vitamin D axis, or also in the sensing axis, which also affect the PTH secretion. So if there is more phosphorus load, if there is respiratory or metabolic alkalosis, exchange transfusion, particularly with citrated blood, there will be chelation. If there is a PTH problem, you will have a high level of phosphorus. This may happen because of deficiency of parathyroid or resistance to parathyroid, hypo or pseudo hypoparathyroidism. You may also have hypomagnesemia, which impairs the PTH effect in that regards. Now, vitamin D deficiency, anti-epileptic use causing inactivation of vitamin D, chronic kidney disease or VDDR1, where the production of calcitriol is defective, or there is resistance to vitamin D, will all cause vitamin D related hypocalcemia. Classical presentation will be hyperparathyroidism and hypophosphatemia. So phosphorus levels, if they are low with hypocalcemia, think of a vitamin D cause. If phosphorus is high, think of a PTH cause. Now, calcium sensing receptor defect, I've already alluded to, is a very interesting and a unique defect in which you will have hypocalcemia with hypercalciuria. So hypocalcemia could be because of ionic deficiency, because of chelation due to hemolysis, tumor lysis, blood transfusion, or alkalosis, in which you will have classical clinical picture, and phosphorus may be high in that scenario. You may have decreased total calcium because of a vitamin D related cause, because of deficiency, inactivation, chronic kidney disease, or vitamin D dependent rickets type 1 and 2. Classically, you will have hypophosphatemia with rickets, while you may also have a PTH related cause because of hypoparathyroidism, pseudohypoparathyroidism, kidney abnormality, where you will have a high phosphorus and you will have calcification. So I think I'll close at that point of time, and I will now request Vibha to start her part of the session about etiology, which will cover the various aspects. So over to you, Vibha.
Thank you, sir. Let me share my slide.
Are you
Is it
not able? Not yet. You shared the screen, I think, first.
Sir, just a second.
Yeah, now your screen is visible. You can now open the PowerPoint.
Yeah, yes, sir. Is it visible, sir?
Not yet. We are seeing your screen, but not the PowerPoint. I think you open the PowerPoint first. You stop the screen share. Open the PowerPoint. Yeah, now it's visible. Now you can go into the slideshow.
Okay. Okay.
Yeah.
Thank you very much, sir. So, sir has already given the overview of the etiology, and I'll explain one by one in the following slides. Now, coming to the etiology, knowing the etiology of hypocalcemia is very important because it will help us in deciding the workup plan. So, let's begin with the etiology of hypocalcemia, starting with the increased chelation, starting with the transient hypocalcemia. So, it is a very common entity of the hypocalcemia, which is generally seen in the newborn neonates. And it is, as we all know, there is a physiological dip in the first 24 hours of life post-neonatal. And when there is an exaggeration of the physiological dip, it will result in the transient hypocalcemia. And see, what are the factors that can cause transient hypocalcemia? It can occur in the setting of birth asphyxia, which could cause high calcitonin level and high phosphorus level. Another cause, it can be seen in the setting of infant of diabetes mother, where there is a low magnesium levels and there is an impaired PTH axis. Now coming to the most common cause, that is the prematurity. As sir has already discussed that most of the calcium is transferred from the mother to the fetus, mostly in the third trimester. And for the premature babies, they don't get enough time to fulfill their stores. So definitely they have very low stores of calcium in them. So it causes the transient hypocalcemia in them. And other factors could be they have immature PTH axis. And due to the low store, they have transient hypocalcemia. Now moving towards the hypomagnesemia, it is very important common cause of hypocalcemia because magnesium is very important and it is very essential for the PTH release and its action. As calcium acts on the calcium sensing receptor, the magnesium also acts on the same receptor. So when there is an excess or there is a high levels of magnesium in the blood, it will act on the calcium sensing receptor and it will further decrease the PTH level and it will decrease the PTH release and it will cause the hypocalcemia. On the other hand, when there is a mild magnesium deficiency, it will inhibit the type 1 PTH receptor and along with it, it will also impair the function of 1-alpha hydroxylase, which is present in the proximal convoluted tubule, which will further cause the hypocalcemia. But when there is a very low level of the magnesium, like in the severe hypomagnesemia, it causes defect in the calcium sensing receptor and then it causes the decreased secretion of the PTH. So whether the magnesium level is high or whether it is low, in both the ways, it will impair the PTH secretion and it will cause the hypocalcemia. Magnesium levels and the PTH levels have an inverted J-shape association. The PTH levels are very low when when there is a severe magnesium deficiency. The PTH levels start rising when the magnesium level is around 0.6 millimole per liter. It will continue to rise and become stable till 1.2 millimole per liter. And after 1.2 millimole per liter, the PTH level will start falling down. So when there is a total body magnesium deficiency, definitely it will cause impaired PTH secretion instead of the normal serum magnesium. So we should always keep our ears and eyes open. In the case of hypocalcemia, always check out the magnesium levels, whether they are high or whether they are low. So moving towards the next cause, vitamin D related causes. As Dhwani has already mentioned that most of the pediatrician or the PG students, this is the most common cause that they are going to face, the vitamin D related causes of hypocalcemia. And what happens here? The low exposure of sunlight. As we all know, sunlight is very essential for the conversion of whole calcium salt to the vitamin D. So when the areas where there is low sunlight, where the people who are not exposed to sunlight, they are more prone to have vitamin D deficiency related hypocalcemia. Another cause could be like liver disease, where there is a impaired action of the 25-hydroxylase. Another could be like inactivation by the use of antiepileptics like the phenytoin, carbamazepine. In the CKD and the vitamin D dependent rickets type 1, where there is an impaired activity of the 1-alpha hydroxylase, it will also lead to the hypocalcemia. And the last one is the resistant to the action of calcium. That is the vitamin D dependent rickets type 2. So in all the cases, we'll get low phosphorus, and the presentation will be like around after 3 to 6 weeks. The vitamin D deficiency will not present like in the very neonate periods. They will only occur after the period of 3 to 6 weeks. And this is very important point, like when there is a chronic vitamin D deficiency, it will lead to PTH resistance. And what happened in that? See, in the PTH resistance, the PTH levels are good, but the action is impaired. So they will present with hypocalcemia, high phosphorus level, and high PTH level. So in any neonate or infant, if you are having like hypocalcemia along with high phosphorus levels and high PTH level, you should not conclude to that this is PHP, which is pseudo hypoparathyroidism, because PHP does not occur in a neonate PP, and it never present with a frank hypocalcemia in a very early age. So if this presentation comes to you, always think that this PTH resistance could be due to chronic vitamin D deficiency, and always check the vitamin D levels in that case. So hypoparathyroidism, in which there is deficiency of parathyroid hormone. And what does parathyroid hormone do? As sir has discussed already, that the role of parathyroid is to bring out the calcium from the bones and increase the calcium level. So when there is a PTH levels are low, the calcium will not come out from the bone. It will cause hypocalcemia. The PTH is also responsible for the calcium absorption, that 5% calcium absorption from the DCT. So it will not able to absorb the calcium. It will cause the hypercalciuria. And the PTH is also responsible for the phosphate excretion. So in the low PTH levels, there will be hypocalcemia along with the high phosphoric levels with the low PTH levels. And one thing more, the PTH is also responsible for increasing the activity of 1-alpha hydroxylase. So when there is a low PTH level, the level of calcitriol will also be low, which makes the intestine more permeable to the calcium. So it will also decrease the absorption of calcium in the hypoparathyroidism. So the patient will have high phosphorus, inappropriately low PTH, and definitely they're present after 3 days, not in the very early period like after 4 to 3 days. So always keep in mind that if the patient is present after 3 days, there could be like you should keep that it could be like hypoparathyroidism could be the cause of hypocalcemia. So moving towards the next, calcium sensing receptor defect is a very interesting cause of, I would say, of hypocalcemia. As the work of calcium sensing receptor is to regulate the calcium level in the blood, and they are present in the parafollicular C cells of the thyroid, in the this parathyroid gland, and also in the proximal tubules of the kidney to absorb the calcium. But when there is an activating mutation of the calcium sensing receptor, what the body sense like, yeah, I have a lot of calcium inside me, and I want to excrete it. I want to get rid of this calcium, and it decreases the PTH level and increases the calcium excretion. So it will decrease the PTH, it will increase the calcitonin, and it will present with hypocalcemia and hypercalciuria, and they will be high phosphorus. Now, coming to the 22 deletion syndrome, this was mentioned in the first case by the sir. It is caused by the defect in the gene TBX1, and it involves many systems like thymus, anatomical defects of the face, anatomical defect of the outflow of the heart. And what does it happen? In 22 deletion syndrome, there is a contiguous gene deletion. And what does it mean? It means that the presentation will be variable, and the presentation will depend on how many genes are gone or deleted. So there will be variable presentation of this 22 deletion syndrome. And it has many names. It is known as DiGeorge syndrome, as we all know, velocardiofacial defect, monotruncal anomaly facial. Now coming to the DiGeorge, how does the DiGeorge syndrome present? And recently we have managed this DiGeorge syndrome in our hospital. The patient classically present with the facial features of cleft lip and the cleft palate, compressed facies, and the low-set ears. And the patient will have recurrent chest infection due to thymic aplasia. And there is a very important point I want to highlight here, that thymic aplasia is very non-specific feature of DiGeorge syndrome. Like if you're finding absent thymus in the X-ray, chest X-ray, you should not conclude to the diagnosis of DiGeorge syndrome, because on the other hand, if there is a thymus aplasia, you should at least suspect. You can suspect, because this is a very non-specific feature of the DiGeorge syndrome. And there is low T cell count. The cardiac features all involve the conotruncal defect, and it includes like tetralogy of Fallot, VSD, vascular ring interrupted arch, truncus arteriosus, and it presents with hypocalcemia, which can be variable, which can have variable presentation. It can present either in the infancy or in the puberty also. And this is very important, like the hypocalcemia in the DiGeorge is precipitated, is exaggerated by the use of furosemide. Because what does furosemide do? It causes hypocalciuria. It excretes the calcium from the body, so it will excrete the hypocalcemia. So never use furosemide in the patients of DiGeorge syndrome. And it has other associated features like anal or esophageal atresia, dysplastic kidney, and ocular malformations. Now coming to the infiltrative disorders. Among the infiltrative disorders, autoimmune is the most common one. And within the autoimmune, APS1, which is autoimmune polyclanular syndrome type 1, is the most common. And it is caused by the defect in the AIR gene. Others are APS2, which involves mostly the adrenal. Also, hemochromatosis is one of the infiltrative disorder, which could be caused by the repeated transfusion in the thalassemia patients or the primary iron overload. It presents with the pigmentation and gonadal failure. Also in the Wilson's disease, which present with neurological psychiatric features, and they have high urinary copper. Now coming to the APS1, the first clinical manifestation that the patient of APS1 will have is the mucocutaneous candidiasis. It presents with the age group of 2 to 5 years, and it is universal. It is always the first manifestation. Now coming to the preceded by the mucocutaneous manifestation, they'll have hypoparathyroidism, which occurs in the age group of 5 to 7 years, and hypoparathyroidism is the first endocrine manifestation of APS1. Later on, the adrenal glands are also involved around the age group of 10 to 20 years, and they will present as primary adrenal insufficiency. They could also have transaminitis, urticaria with fever. In some patients, urticaria with fever could also be the first clinical manifestation. Rarely can have GI symptoms, constipation, diarrhea, keratoconjunctivitis, pneumonitis, and Cochran-like syndrome. Okay, now coming to the PTH signaling defects. These are very interesting defects. If we really go into the etiology of it, the type 1 PTH receptor. Let's talk about the PTH-RP first. The PTH-related peptide. It is the most common or the most important paracrine hormone which is required for the chondrocyte growth. Okay, so for the fetal to develop, for the fetus to grow, PTH-RP is required, and both PTH-RP and the parathormone acts on the same receptor, that is the type 1 PTH receptor. Okay, so if the patient is having hypoparathyroidism, the hypocalcemia in those patients will not be that severe. The fetus can grow without PTH deficiency because they will get the calcium from the mother. But in case where there is a PTH-RP problem, or in the conditions where there is defect in the receptor on which the PTH-RP works, in that condition, the fetus will not able to grow. There will be intrauterine growth retardation, and this intrauterine growth retardation is also known as Bloom-Strand chondrodysplasia. The chondrocyte won't grow; they will be dysplastic chondrocytes. Okay. Now, coming to the PHP, what is PHP? PHP is a pseudo hypoparathyroidism, and the PTH acts on the PTH receptor, and it also via the alpha subunit of the G protein, it starts its work. So when there is defect in the alpha subunit of the G protein, it will cause PHP 1A and 1B. I'll describe what is 1A and 1B in the following slides. Let's see what is the classification is. And when there is a defect in the linkage between the PTH receptor and the alpha subunit, it will cause PHP 1 type C. And when there is a problem after the cyclic AMP production, then it will cause PHP type 2. And there is another entity known as acrodyssostosis type 1, which is caused by the defect in protein kinase A. And acrodyssostosis 2 is caused by the defect in the protein phosphodiesterase. So coming to the what is PHP type 1A? See, there are so many tissues in our body. Every tissue has a genetic expression, and each gene is inherited from either by the mother or the father. Okay, so in the PHP type 1A, when this defect is present in the mother and that defect is inherited from the mother, that will cause PHP type 1A. And as there is a defect in the alpha subunit, there will be no cyclic AMP formation and there will be no phosphorus response. And the patient will present with a manifestation of skeletal dysplasias like Albright hereditary osteodystrophy, which is characterized by round facies, brachymetacarpia, obesity, ectopic calcification. It could be intracranial or subcutaneous. This is the picture showing the brachymetacarpia. When you will ask the patient to this clench your fingers, and you will see the depression between the third and the fourth metacarpal, that is the brachymetacarpia. Intracranial calcification is also the manifestation of PHP type 1A, and this black dot in this is sole is the subcutaneous calcification. And there is also resistance to other hormone which presents like obesity, high TSH with normal T4, pubertal delay, which is commonly seen in girls, and the growth failure. But there will be no hypocalciuria. Let me explain one thing here. If we talk about the calcium absorption, the distal part where the 5% of the calcium is absorbed, it has genetic expressions, both controlled by the mother and the father. And if there is a genetic defect from the mother, the normal father gene will take care of the absorption of the calcium. That's why there is no hypocalciuria in the PHP type 1A. Now coming to how PHP type 1A is different from PPHP, that is pseudo hypoparathyroidism. As I've already told that PHP type 1A is caused by inheriting the defect from the mother. On the other hand, PPHP is caused by inheriting the defect from the father. And type 1A will manifest like hypocalcemia. They will have bony disease, which is found in a cluster and known as AHO, that is Albright hereditary osteodystrophy. And while on the other hand, the pseudo hypoparathyroidism will only have bony manifestation. They will only have AHO phenotype, and they will have normal calcium. As I already told you that the calcium absorption is controlled by both mother and the father. So if one gene is affected, the mother gene will take care of the calcium in this PPHP. So they will have normal calcium and they will only present with bony manifestations in the form of AHO. Now, if I summarize all the PHP in one table, all PHP will have low calcium except for the PPHP, that is pseudo hypoparathyroidism. All PHP will have HO phenotype except for the type 1B and type 2. All will have low urinary calcium, low cyclic AMP except for the type 2 and PHP. Hormonal resistance to the other hormones like TSH, FSH and GnRH will be seen in type 1A and type 1C, but in type 1B and PPHP, there will be no hormonal resistance. So, and I have already told you, like pseudo hypoparathyroidism also presents like chronic vitamin D deficiency. So when there is a hypocalcemia, high PTH level and high phosphate in the older age group, you should always, and when there is a AHO phenotype, that is the round face, she is obesity, you should always keep in mind that it could be due to PHP.
Thanks, Vibha. So for the wonderful introduction with regards to the etiology, we will now move forward towards the criteria part and how do we assess a patient with hypocalcemia and the management part. So before we start that, we'll see if there are any particular question there. So Dr. Narendra is asking, do we need to check for maternal calcium, vitamin D every time in neonates? We'll touch base about that when we talk about this part on that. So now we already know about the etiology of hypocalcemia. There are three basic questions which we have to answer. Is it really hypocalcemia? If it is hypocalcemia, what is the site, whether it is vitamin D or PTH, and finally, what's the cause in that perspective? So when do we suspect hypocalcemia? Already we have discussed this, and Vibha also mentioned that anybody with seizures, apnea, and tetany, we all know that this is hypocalcemia. We also need to think of hypocalcemia in the setting of seizures, particularly in children with seizures, where often calcium is not done in everybody. Cardiac failure and cardiomyopathy, which may be an important etiology. Intracranial calcification, very important in the setting of chronic hypocalcemia. Raised intracranial hypertension, benign intracranial hypertension, headache and visual complaints, again very important. Stridor, which is again a marker of laryngospasm, and cataract, which is a marker of chronic hypocalcemia. So any of these settings you should evaluate immediately for calcium levels. Of course, if there is a preterm baby or somebody who is small for gestational age and has got features of DiGeorge syndrome, we have to think of a possibility of hypocalcemia as well. Now, very importantly, we may sometimes not have features of hypocalcemia, but we have latent features like Chvostek sign. So if you tap around the facial nerve, you will see twitching of the eye, and you have Trausius sign when you make decreased blood flow ischemia. There will be a tetany which will be induced, and you can use these signs to identify hypocalcemia in that regards. When you're assessing calcium, remember it should be done in a serum sample in the fasting state. The problem, of course, is that if there is hypoalbuminemia, the calcium levels may be falsely low, and if the protein levels are high, you may have false hypercalcemia, which you have to be wary and aware about that. We can correct the calcium. So for every 1 gram per DL decrease in albumin, the calcium goes down by 0.8. So you can correct it by adding 0.8 milligram per DL per albumin decrease from that regard. So we already discussed that we need to have different figures for preterm and term infants. So anybody based upon birth weight less than 7 total and more than 1500 less than 8 becomes significant. Beyond the neonatal period, we have a normal range of 8.6, which defines hypocalcemia. And of course, ionic calcium would be preferable in that regards. Preterm babies will have lower levels as discussed. One of the very important aspects to assess in the setting of calcium deficiency is also serum phosphorus, which should be done in the morning fasting state. The caution, of course, here is that you should not be using a tourniquet or a squeeze sample, because this basically is an intracellular ion and you may cause raise in terms of these levels. We have to interpret in terms of age-specific levels, which becomes very, very important. And phosphorus levels tend to be high during infancy and childhood because they are markers of bone formation and bone turnover, and phosphorus levels need to be corrected. And often if we look at the adult data, we may falsely say the phosphorus level is high when it is actually normal in that regards. And this is something important we'll discuss subsequently in that perspective. Now, once we know this is hypocalcemia, the next issue is, of course, further evaluation. So, of course, if we have very early onset neonatal hypocalcemia in the first 3 days, we have to think of a possibility of prematurity, small for gestational age, and infant or diabetic mother. There is also a possibility that the mother may actually have hypercalcemia, and because of this hypercalcemia, the PTH gland gets suppressed, and there is a rebound hypocalcemia which may happen in the children. And this is something that's why the maternal calcium becomes very important to assess in that regards, and that's an important part to look at from that perspective. Now, beyond that, depending upon the duration from 3 days to 3 weeks, the possibility we have to think of a hypomagnesemia and hypoparathyroidism as important causes. And as discussed earlier, beyond 3 weeks, vitamin D deficiency becomes an important cause to evaluate. We have to, of course, look for mother's history of diabetes, eclampsia, hyperparathyroidism, and assess calcium phosphorus, as we were discussing, to identify this case. In children, of course, we have to look at the gestation, the birth weight, the Apgar scores to look at hypoxia, exchange transfusion, feeding, and all those regards become important. Examination should look at the facies to look at specific features for DiGeorge syndrome, look for cleft lip, cleft palate, have a careful cardiac evaluation, look for murmurs and features of DiGeorge syndrome and rickets, which become important. In the post-neonatal period, we have to look for features of hemolysis, tumor lysis, or rhabdomyolysis. If there are nails which are atrophic, think of a possibility of autoimmune polyendocrinopathy, as Vibha was talking about. And if there is rickets, think of a vitamin D dependent causes. Specific history for phenytoin, phenobarbital, which can really impair the vitamin D. Metabolism becomes important. And if you have brachymetacarpia, short fourth metacarpal, calcification, cataract, think of pseudohypoparathyroidism as a possibility. Recurrent infection in a child with absent thymus, think of DiGeorge syndrome as a possibility in that regards. Also ask for features of renal failure, liver disease, and malabsorption. The initial workup and the most important test to look at in the setting of hypocalcemia is phosphorus. So we expect the phosphorus to be low in hypocalcemia. If your phosphorus is high, think of a PTH related cause. Creatinine, of course, to rule out renal failure. Magnesium in anybody who has chronic hypokalemia, chronic hypocalcemia, measure magnesium levels. And if the urinary calcium is high in the setting of hypocalcemia, think of a calcium sensing receptor defect, which can cause an issue in that regards, and that will become important from that perspective. Now, further workup is guided based upon the basic investigation. So if you have a high phosphorus with a normal renal function, the most important test here to look at will be a parathyroid hormone, which becomes relevant. If you have a low phosphorus, look at magnesium first. If magnesium is normal, look at vitamin D and then go for calcitriol. Look for lymphocyte, and of course, if the lymphocyte counts are low, think of a possibility of DiGeorge syndrome, for which fish would be the appropriate investigation. You may rarely have a mildly elevated TSH, which may be a marker of pseudo hypoparathyroidism. So very important to remember is that there is a relationship between PTH and calcium. If your calcium is low, your PTH should be sky high. So even if you have a normal PTH with a low calcium, that is very, very important, and that may suggest a possibility of hypoparathyroidism. Remember that the parathyroid hormone is thermolabile, has to be transferred in ice, otherwise there would be a risk of falsely low level of PTH, and you need to have a contextual assessment. So if your calcium level is low, the PTH level should be high, and this is clearly a pseudo hypoparathyroidism or a normal response. If your PTH is low or normal, that is hypoparathyroidism. Now, if we now look at in terms of the key investigations of phosphorus, PTH, vitamin D, calcitriol, and urinary calcium. In vitamin D deficiency, so we expect phosphorus to be low in everybody, and of course, urinary calcium will be low in the setting of vitamin D deficiency. In vitamin D dependent rickets, the 25 hydroxy vitamin D levels will be normal, but calcitriol will be low, so there's a problem in calcitriol production. While in VDDR2, your calcitriol levels will be high. On the other hand, if your phosphorus is high, rule out renal failure. If that is normal, creatinine is normal, think of a pseudo hypoparathyroidism in which PTH is high, and hypoparathyroidism and calcium sensing receptor defect where your levels of PTH are low. So the key investigations are phosphorus, PTH, and creatinine, and if required, 25 hydroxy vitamin D and calcitriol to reach a diagnosis. So the initial evaluation is to look at the magnesium, albumin, and phosphorus load. If they are not there, the phosphorus level is low or normal, get a vitamin D level. If vitamin D is low, this is vitamin D deficiency. If vitamin D is normal or high, get a calcitriol level, which is low is VDDR1. If it's high, it is VDDR2. While if your phosphorus is high, you're dealing either with renal failure or a possibility of a pseudo hypoparathyroidism. If creatinine is high, you confirm your diagnosis of renal insufficiency. If creatinine is normal and PTH is low or normal, this is hypo. While if it's high, it is pseudo hypoparathyroidism. So the most important tests are magnesium, phosphorus, and creatinine, and then you can go ahead with PTH, and vitamin D required in certain cases, definitely calcitriol only in the rare cases from that regards. So we have this 4-month-old boy with nephrotic syndrome, and what we see that the calcium levels were reported as low, but this child is asymptomatic. So here important thing is to correct for albumin, which was very, very low. And in this setting, once we corrected, it was normal. So whenever you have a total hypocalcemia in the absence of symptoms, you have to confirm the actual ionic levels, which become important. A 4-year-old girl with tetany and a low level of ionic calcium, what you are seeing is that the phosphorus is very high. So this is hypocalcemia with hyperphosphatemia. We're not dealing with vitamin D related causes here. The PTH is high. A diagnosis of pseudo hypoparathyroidism was made. But if we look at our algorithm, if your phosphorus is high, the first thing to look at is creatinine. Now, what we are seeing here is that creatinine is high, making this a renal failure. So PHP should not be rushed out as far as immediate diagnosis is concerned. 1-year-old boy with neonatal seizures and is very severe hypocalcemia, total calcium of 5.4. Phosphorus is slightly on the higher side, though it is within the normal range for the age. PTH is not that elevated, it's inappropriately low. So this looks like a hypoparathyroidism. There is no response to IV calcium. This is a classical setting of hypomagnesemia. So when we checked the magnesium levels, they were really low. We did not find a urinary magnesium to be very high. It was found to be a TRMP6 defect, which is a transporter both in the intestine as well as in the kidneys. We required a very, very high dose of magnesium, around 20 times the normal dose, to achieve the response. 3-month-old girl with seizures and ionic hypocalcemia, which is proven, with a low level of phosphorus and also a low level of PTH. Now, both of them don't go hand in hand. If your PTH is low, phosphorus should have been high. So what's the problem? So when we thought of this as a hypoparathyroidism, it was very unlikely given the picture. So we evaluated for vitamin D level in this setting, which was found to be very low. Now, this is a classical scenario in which the PTH is not done appropriately. PTH is a thermolabile hormone. If it is not taken and transported appropriately, there would be a risk of falsely low levels, which was identified in this case. Now, we have a 1-week-old boy with seizures and ionic hypocalcemia. Phosphorus levels are very, very high. So hypocalcemia, hyperphosphatemia, excluding vitamin D related causes. Now the creatinine is normal. So we are dealing with a PTH related cause. The PTH level is low, suggesting hypoparathyroidism, but your job is not done. When you have such a young infant with hypoparathyroidism, think of DiGeorge syndrome. Look for the faces, look for the facial features, look for the cardiac defect, and do a FISH to identify this, because there is huge implications in that setting. Now, again, we have a 4-week-old boy with seizures with severe hypocalcemia. The phosphorus level is on the higher side. The creatinine is normal. So looks like a PTH related cause. PTH is high. So now, are we dealing with pseudo hypoparathyroidism in this case? Now, what Weber has already said, that this is not the right age for pseudo hypoparathyroidism to emerge. And we need to remember that in cases of chronic vitamin D deficiency, there is an induced PTH resistance, which is reversible. So hypocalcemia, hyperphosphatemia is not always with high PTH suggestive of PHP. Exclude vitamin D deficiency, particularly in infancy. And vitamin D was very low. Once we corrected vitamin D, there was an improvement in terms of response, which was observed in this setting. 5-year-old boy with tetany, hypocalcemia, again with a very high phosphorus. Phosphorus is exceedingly high. Normal creatinine. PTH is on the lower side. So this is an interesting case. Looks like a hypoparathyroidism. And there was also a pigmentation which was there. And this case classically happened to be hypoparathyroidism, was started on calcium and calcitriol, but presented sometime later with hypercalcemia, along with symptoms of weakness, lethargy, and hyponatremia. So this is a very, very important scenario. A child with hypoparathyroidism who was well controlled suddenly presents with hypercalcemia, reduced calcium requirement. Think of a possibility of a cortisol deficiency in the setting of an autoimmune polyendocrinopathy syndrome. So hypercalcemia in hypoparathyroidism, think cortisol deficiency, that becomes important. So this was APS in that regard. So in the final case, 10-year-old boy with seizure, then we can see there was a cataract, there is calcification in the intracranial region, there is brachymetacarpia, and this clearly was suggestive of a case of pseudo hypoparathyroidism. Phosphorus was sky high, creatinine was normal, and in that scenario, PTH was high. So this is classical PHP, stocky build, short stature, overweight, cutaneous calcification, intracranial calcification, brachymetacarpia, cataract. So here you should think of PHP. So now we have gone through the overall overview with regards to the overall assessment. Now we'll quickly go through about management, which is largely the acute management. So as with other causes like hyponatremia and other scenario like hyperkalemia, management depends upon symptoms. So if the symptoms are there, give calcium gluconate 1 ml per kg of 10%, and we may repeat if the symptoms are present. After that, start infusion. Now, the problem is most people give recurrent boluses of calcium, which causes loss of calcium in the urine. It's always better to give 10 ml per kg per day, which is like 90 milligrams per kg per day in infusion fluid. And then you add calcium and calcitriol. Very importantly, if you do not add calcitriol, your vitamin D levels will not build. And once you stop infusion, you will develop hypocalcemia. Now, if there are no symptoms, but the calcium levels are very low, and we have mentioned that as preterm below 6, term below 7, and postneonatal below 7.5, roughly 1.5 millimoles, 1.75, and around 1.9 millimoles per liter. In that scenario, you should start with infusion. No need of giving acute bolus. If there are no symptoms, start with calcitriol. Now, this calcitriol is only to build up the vitamin D level because the half-life is short, and then you can start with the long-acting vitamin D. In that perspective, then no response, you can go ahead with again infusion in that perspective. Now, very importantly about the chronic cases of hypoparathyroidism and pseudohypoparathyroidism, the treatment largely is in the form of calcium, which is given at a high dose, 50 to 75 milligram per kg per day, up to 3 grams in adults, and calcitriol, which is given as 25 to 50 nanogram per kg per day. You titrate the calcium level, especially in hypoparathyroidism, maintain a calcium around 8, 8.5 because of the risk of hypercalciuria. In pseudohypoparathyroidism, maintain around 9.5 to 10 to avoid the skeletal damage which will happen. You can also use alpha calcidiol if there is a clinical scenario. So we have now gone through the overall aspect of the pathophysiology, the etiology, and the approach. Now I'll invite Dr. Dhwani to come into the picture and start the OSCE. We will also like you to answer the questions on a Q&A format. So Dhwani, you can come in now.
Thank you, sir. So yes, I think sir has very well explained the topic, and this is a very short part. So let's start with the quiz. So we have a case, 9-year-old boy with short stature with poor appetite, nausea and vomiting. There's a past history of poor urinary stream with history of PUV. The child underwent fulguration at 5 years of age. On examination, the child has failure to thrive with weight and height below -2 STS, acidotic breathing and pallor. The investigations show anemia, serum creatinine of 1.9. Apart from that, the other workup was essentially normal. Mild metabolic acidosis, pH of 7.1, bicarb 18. So now this child was diagnosed as CKD, started on nodosis and K-bind. 1 week after starting therapy, the child developed carpopedal spasm. So what has happened, and how could this have been prevented?
You can answer on the chat, the Q&A or the chat, you can answer, and we can then go from there. So what do you think has happened? You have a child who had long-standing hypocalcium stores which were low, but suddenly he has developed hypocalcemia now. So while people answer, Dr. Dhwani, what do you think could be the reason?
So here, the important thing to note is that nodosis was started. On starting alkali therapy, there is a shift of ionic calcium to the bound form because of increased negative charge.
That's a very, very important point. When you increase the alkalotic level, the anionic albumin increases, the calcium level goes down. And Dr. Barani said that we should have added calcitriol at that point of time. I think that's a very, very important point from Dr. Barani. We'll now move forward to the next one. So, yeah.
Moving on to the next case. Yes, we have a 7-year-old girl, case of nephrotic syndrome. She underwent a routine panel of workup, and on investigation, she was found to have calcium of 7.9. So the doctor went ahead and did the phosphorus, PTH, vitamin D levels. Phosphorus was normal, PTH was 32, so in the normal range. Vitamin D was again in the adequate levels. The child was, however, referred to you for hypocalcemia investigation. So in the presence of low calcium, this normal PTH, do you think this is hypoparathyroidism? Would you like to work up this child for hypocalcemia? And
yeah, the first question is whether it's hypoparathyroidism. You have a low level of total calcium and a PTH which is inappropriately normal. So I think we'll take answers from that. Meanwhile, there are a few answers from the previous one. Dr. Sekhar Malidi has mentioned alkalosis worsened hypocalcemia. Absolutely right for the last one. Now, in this case, whether we really think this hypocalcemia. Yes, Dr. Anand has mentioned that this is because of hypoalbuminemia. So Dhwani, this is not really hypocalcemia, so it's not hypoparathyroidism.
Yes. And
how would you calculate the corrected calcium?
so again, 4 minus 1.5, that is the serum albumin level mentioned here. So that is 2.5 into 0.8. So yeah, so we have calcium definitely.
So in that case, the calcium will be 9.9. So this is not really a calcium deficiency in that perspective. So we have these two interesting cases. Now we'll move forward to the third scenario.
Again, we have a 4-year-old boy with failure to thrive. As we can see, the weight is minus 3.9 Z scores. The height is at minus 1.9. The mid-arm circumference is low. The child is irritable, has a loss of buccal fat pad that you can clearly visualize. Now here, as you can see, the corrected calcium is also on the lower side, 8.2. So again, the doctor went ahead with investigation. Your PTH is 32. Vitamin D levels are extremely low. Phosphorus is again on the lower side. What is the cause of hypocalcemia here, and how would you go to correct it? Knowing that this child is not acutely symptomatic at present, the hypocalcemia that you can see was only present on investigation.
So we will seek responses. So this child is asymptomatic hypocalcemia with a low phosphorus and a low vitamin D. Now, this vitamin D level is not that low, Dhwani, which we normally see in the setting of vitamin D deficiency. Yeah, so vitamin D deficiency causing hypocalcemia, the levels are very low. So do you think something else might also be contributing? So we have answers, nutritional rickets from Dr. Bhanani, which definitely vitamin deficiency is playing a role. Vitamin deficiency again, Dr. Shekhar, but any other thing other than vitamin D that we'll think of?
Magnesium deficiency.
Yeah, so magnesium also becomes absolutely important. So we have got vitamin D and magnesium both in this setting.
And that is again, the magnesium deficiency is causing, is making the PTH levels not rise appropriately as they should have actually in the setting of hypocalcemia.
And what's the other marker of magnesium deficiency in this case, Vibha?
Another marker, sir, potassium is also on the lower side.
Yes, so there is hypokalemia, hypocalcemia. Of course, look at magnesium. So vitamin D and magnesium both. Generally, when I talk about hypocalcemia, which is severe, vitamin D is less than 5. So there is some other thing which is playing a role here in this case. Yeah, next case.
A 10-day-old girl with focal seizures for 1 day. She was born term by cesarean section. Birth weight was normal, 4 kgs. On examination, she was not febrile. She had no obvious dysmorphism. On investigation, what we found was that the sepsis screen was negative. Calcium was very low at 6.7 with an ionized calcium of 3 milligram per deciliter. PTH level was 130, vitamin D levels were low, and of course for seizure, sugars were confirmed to be in the normal range. So in the setting of this child with hypocalcemia, what other family member would you like to screen here? And how will you manage this hypocalcemia? What route of calcium, how will you treat this hypocalcemia?
So this is again an interesting case, a sort of a early onset sort of a thing. Hypocalcemia, so maternal, yes, Dr. Robert Hamilton is mentioning that we should do maternal calcium phosphorus ALP, very important because of 2 reasons. One, rare possibility whether there is a hyperparathyroidism there, and sometimes vitamin deficiency can also present in this age group. So we need to be aware about this case. So there's a low vitamin D, so mother should be screened. Now, the other big question is, what sort of treatment would you give for this child? So Vibha, what would you think at this point? The child has seizures.
Definitely the child is having symptomatic hypocalcemia, so we should do the acute correction.
Yeah, so we have to give intravenous calcium bolus followed by infusion. And very importantly, which we mentioned earlier, that you should always give calcitriol in this setting, otherwise they will have a recurrence of hypocalcemia. So a 3-day course of calcitriol is usually good enough in that regards. Yes. So next case, Dhwani.
So in the same, in the mother of this child, she was a 24-year-old female, had no major complaints, no significant history in the antenatal period or past illness. However, on investigation, she was found to have hypercalcemia with phosphorus on the lower side and PTH high, 230, high PTH levels. Her urine calcium creatinine ratio was high and ultrasound showed nephrolithiasis at lower poles.
So what are we dealing here? This mother, we thought it could be vitamin deficient, but suddenly she is hypercalcemic. So anybody can have a guess what is the problem here? So this is a rebound. So like infant or diabetic mother is diabetic, child becomes hypoglycemic. Here the mother is hypercalcemic, the child becomes hypocalcemic because PTH axis is independent of the maternal growth. So if your calcium is high in the mother, calcium is high in the baby, PTH axis gets suppressed. After birth, you have hypocalcemia. So as discussed earlier, and Dr. Anand has already mentioned, maternal hypercalcemia is the cause of hypocalcemia in this scenario. So we'll move forward to the next scenario.
Okay, so we have 10-year-old boy with seizure. Calcium was 7.2, albumin was normal. So we know the corrected calcium was definitely low. Serum creatinine was normal and PTH was very, very high. So high PTH, low calcium.
So you've got hypocalcemia, hyperphosphatemia, and hyperparathyroidism. So I think this is very important. We showed this case. So which clinical clue will give you the diagnosis right away? And we'll see if somebody answers that question. So this is an older child, not a very young child. And the PTH is high. Of course, creatinine is normal. So there's only one possibility as we discussed. Creatinine is normal. So brachymetacarpia, obesity, calcification, cataract, all those for pseudo hypoparathyroidism. And which of the parents may have hypocalcemia in this case, mother or father? So we like to have input from the audience, whether the mother will be affected or the father will be affected with hypocalcemia. So, Vibha, what do you think? Who would have been affected?
Mother will be affected. Mother will have hypocalcemia.
Yes. So pseudo hypoparathyroidism is an imprinting defect in which the manifestations depend upon the inheritance from the parent. So there is a maternal inheritance. If you get it from the father, you will develop only skeletal manifestations, but you will not develop hypocalcemia. So again, this is an important thing to remember. So we will move forward towards the next case. Again, Dhwani.
Okay, so 8-year-old boy with hypocalcemia, he was diagnosed with hypoparathyroidism, was started on calcium and calcitriol supplements. Now mother has noticed an increased pigmentation and white coating of tongue that she has noticed for a very long time, but never really paid an attention to. So do you think this hypoparathyroidism was transient and is getting better now? And
so again, this is a very important scenario. Somebody who is hypoparathyroid, if you have treated them, it is very difficult to get their calcium in the normal range. Whatever dose you use, it's very, very difficult. So suddenly if you develop hypercalcemia, suddenly these things happen, you have to be worried about that. So this is Dr. Shekhar has already mentioned, Dr. Irshad has already mentioned, this is APS1, Dr. Bharani. So all three were very quick. So anybody who has got hypoparathyroidism in childhood beyond the typical age for Dijon syndrome, think of a APS as an important possibility. The second most common endocrine manifestation of APS1 is cortisol deficiency. Cortisol deficiency causes hypercalcemia. So I think this is a very classical setting. So anybody who has got hypoparathyroidism with low calcium requirement, diabetes with low insulin requirement, diabetes insipidus with low AVP requirement, hypertension with low antihypertensive requirement, think of an evolving cortisol deficiency. I think that's a big message coming out of that case. I think now we've got some rapid fires. Dhwani?
Okay, so the first one, 50% of total calcium is available in the ionic form. Is that true or false?
So you can just chip in the answer right in the text or the Q&A. Yes, so this is true. Dr. Bharani and Dr. Shekhar are mentioning. I think yes, 50% is ionic and 50% is bound. Next.
Okay, so this was a trick question actually. So 99% of total calcium is in the bones and only 1% is
okay. Yeah, so this was a trick question. Total, you should have mentioned total body calcium. So I think, yeah, so it was a trick one. We could have mentioned total body. Anyway, yeah, we carry forward.
What is the cause of hypocalcemia in a newly diagnosed case of leukemia who was started on chemotherapy?
Yes, so Dr. Irshad has mentioned this is a tumor lysis syndrome. So tumor lysis will release all the intracellular ions, phosphorus goes up, you will have a chelation. Next one.
And okay, so what is the structure? What type of hormone is PTH, and what is the protein, or what pathway does it act via?
Okay, so PTH is we will wait for people to come in. Which type of hormone means which is the chemical composition, the chemical structure, and which second messenger is the one which PTH acts. So we talked about definitely about the second messenger path, about the axis when we talk about pseudo-hypoparathyroidism. So PTH is clearly a peptide hormone and it acts via the G protein coupled receptor. GNA is one pathway through the cyclic AMP pathway. Dr. Musakutti is right at that point of time. Next one, Dhwani.
We have a 2-week-old baby with subtle facial dysmorphism and cleft palate. The echo shows conotruncal defect. What is the condition, and what is the cause of hypocalcemia in such patients?
I think again very nicely discussed via Vibha earlier. So this is anybody in the neonatal period. If you diagnose hypocalcemia, look at thymus, look at cardiac shadow, look at cleft lip, cleft palate, and you will get the diagnosis. This is DiGeorge syndrome. Dr. Irshad is right. Dr. Bharani is right. And this is DiGeorge syndrome with hypoparathyroidism. The fish will give you a diagnosis of the contiguous gene deletion. Yes.
And what is the clinical parameter that must be monitored during calcium infusion, and why?
Yes. So if you give calcium, what may happen? Of course, ECG or the heart, very important. Dr. Bharani has mentioned that. So you have to have a close monitoring of the ECG as well. So I think this was a wonderful session in which we tried to cover a lot about hypocalcemia, which is a common and important condition. All of you can go and have a look at our website, and there are a lot of resources available, the courses which are available, as well as the books and the mobile application. I'd like to thank all of you for patient hearing at this late hour. This session was continuing already for around 75 minutes, and we have got a large number of people who are still around with us and actively participating in the Q&A. I'll thank Vibha and Dhwani for this wonderful interaction, and thank all the audience from across the globe to be part of this program. Thank you. And we will have the next session on hypercalcemia next month.